Hello, my name's Roger Watson, and this session is about screening questionnaires. First of all, how does a screening questionnaire work? Well, a screening questionnaire is just a questionnaire that asks a list of questions, probably related to some kind of disease state, and indicates to the clinician whether that person is likely to have or not have that condition. Please note that a screening questionnaire is not a diagnostic questionnaire. It's screening people into groups, those who are likely to have something and those who are likely not to have something, so that sensible clinical decisions can be made. So once you've completed your screening questionnaire, the score on the questionnaire should indicate whether the person is fit and healthy, or possibly in the worst case scenario, likely to die of that condition. Those are two extremes. They are not the only extremes, of course. So why do we use screening questionnaires? Well, screening questionnaires, as I've already said, can be used to find out if someone has something, a condition, or is likely to have something. For example, depression, problem drinking, an eating disorder, bowel cancer, medications management risk. The range of things that screening questionnaires can be used for is very wide. So why would we use them when a diagnosis is available? And remember, to use a screening questionnaire, it has to be used relative to an absolute diagnosis, a yes or no outcome as to whether that person actually has the condition or not. Well, there are many reasons. Speed and volume is one. We can get through people quickly. We don't have to put them all through a full diagnostic procedure. We have the potential, of course, using them to save lives and to prevent morbidity. We can use resources appropriately. It simply wouldn't be appropriate, for example, to screen the whole population using a full bowel endoscopy for bowel cancer. That would be very expensive and it would go with attendant risks. So using a questionnaire which answers a series of questions which may be related to bowel cancer is one way of seeing whether someone is likely to have it or not, and then to require the full screening or indeed diagnostic procedure. So we can investigate or intervene only when necessary. We lower the risk of dangerous procedures. There are very few internal diagnostic procedures, for example, and I just mentioned endoscopy, that don't have some attendant risks, however small. But how do we decide what the questionnaire is telling us? Well, we need to attach a score on the questionnaire to the level of risk or probability of the actual diagnosis. And there are problems with this. No questionnaire is perfect, and sometimes the questionnaire will give us the wrong answer. The problems there are twofold. One, some people at risk will be screened as being okay. Now, this is the worst possible outcome because those people may subsequently go on to suffer from that condition, and indeed, in serious conditions like bowel cancer, they may well die of it. Alternatively, some people not at risk will be screened as not okay. This is not such a serious outcome, although we may then subject them to a dangerous diagnostic procedure, but we also waste resources. So no questionnaire is perfect, and the design and use of screening questionnaires is all around optimizing their performance and knowing how well they perform. I'm going to use the example of bowel cancer screening, and this is a fictitious example, but there are bowel cancer screening questionnaires. So we could ask a series of questions. Do you have bloating? Yes or no. That can be a sign of bowel cancer. Do you have pain? Yes or no. Have you had a change in bowel habit? Yes or no. That can also be a cardinal sign of bowel cancer. And do you have any blood in your stool? Yes or no. Now, each of these alone can indicate a risk of bowel cancer, but of course we could be bloated because of something we've eaten. Likewise, we could have pain for many reasons. A change in bowel habit doesn't necessarily indicate that we have bowel cancer, and there are other reasons for having blood in your stool. However, if all of these appear together, we may be more worried that someone actually has bowel cancer and may need to investigate further. So if we administered this questionnaire, we'd get a score ranging from 0 to 4. All no's would be 0, all yeses would be 4. Clearly all zeros would be a good sign, and all 4, or all being scored yes and giving a score of 4 would, we think, be a bad sign. However, does somebody need to score 4 in order to be sent for further investigation? In other words, is someone at risk of bowel cancer when they score 1, or 2, or 3, or 4? So which score is useful in screening? Again, the design and the analysis of screening questionnaires is all around that particular question. It all revolves around producing a score on the questionnaire which will optimize our diagnosis, or at least our indication of those who've got something wrong with them, and also those who don't have something wrong with them. So how do we make decisions? Well, there are a range of possible outcomes from a screening questionnaire. There are 4 possible outcomes. It's best represented with a 2x2 contingency table, like this. Along the top we have the true condition, in other words, the outcome of a definitive diagnosis, and on the left we have the test outcome, in other words, the score. So if the condition is positive and the test outcome is positive, we have what's called true positives, people who really have the condition. If, on the other hand, the condition is positive and the test outcome is negative, we get false negatives. So the person has the condition, but the screening questionnaire didn't pick it up. Probably the worst possible outcome. It's also called a type 2 error, but don't worry about that here. If the condition is negative and the test outcome indicates that, then we're getting a true negative. Somebody who really doesn't have anything wrong with them. On the other hand, if the test outcome is positive and the condition is negative, we get a false positive. Someone who doesn't have anything wrong with them, but who probably will be sent for further investigation. Now that's not such a bad outcome, but it does waste resources, and it does put the person at some risk if the diagnostic procedure has any danger attached to it. So these are the parameters. We need a gold standard along the top that tells us whether the person has the condition or does not have the condition, and we need to design a questionnaire which gives us a score and a level at which we make a decision about whether the score is positive or negative. In other words, whether it's screening the person for having or not having that condition. Now, the different boxes in the contingency table can be used to calculate a range of parameters. I wouldn't necessarily try to remember all these. Every time I go to do these calculations, I look them up to make sure I'm getting them right anyway. However, there are 4 different parameters that can be calculated. We're going to focus mainly on sensitivity and specificity and come back later to positive predictive and negative predictive values. So sensitivity is A over A plus C. In other words, that's the numbers that are in those boxes. Specificity is D over B plus D, which is indicates the boxes where those numbers are, and likewise the positive and negative predictive values. The next diagram will make, I hope, will make this a bit clearer, and then we'll go through some examples. So the column entries A and C are used to determine sensitivity. I'll explain these terms very soon. The columns B and D are used to calculate specificity. Rows A and B are used to calculate positive predictive values, and finally rows C and D are used to determine negative predictive values. So what are sensitivity and specificity? Sensitivity, as we've already seen, is calculated using those two boxes here. They're called the true positives over the true positives and the false negatives. Apologies for the slight change in terminology. It's exactly the same boxes, and it would use the same values in those boxes. So the definition of sensitivity. In medical diagnosis, test sensitivity is the ability of a test to correctly identify those with the disease, in other words, the true positive rate. So here's a real example with some numbers in the boxes. Note that they all add up to 100 at the bottom. That's just for convenience. And we know that columns A and C are used to calculate the sensitivity, and if we use the equation that was shown before, using those, we get a sensitivity of 0.66. We'll come back later to discuss whether these values are useful or not. Specificity is calculated using the above columns, and the meaning of specificity is the ability to test to correctly identify those that do not have the disease. These are the true negatives. And using this example again, using columns B and D, we can calculate the specificity is 0.5. So the sensitivity is slightly more than 50% or 0.5, and the specificity is around 50%. You'd imagine that we'd probably miss about half of the cases using the sensitivity, and include about half the cases that weren't real positive or true positives using that specificity. Those values are okay, but they're not very good. You'd hope to aim for higher values. However, I'm just demonstrating here how these values are calculated. So, just to recap, in medical diagnosis, test sensitivity is the ability of a test to correctly identify those with the disease, the true positives, whereas the test specificity is the converse. It's the ability of the test to correctly identify those without the disease, or the true negatives. What we're trying to do essentially is to see if people with the disease and those without the disease, in other words, the TP, that's the true positives, and the true negatives, the TN, we're trying to see if they are in a different distribution. And wherever you get distributions, there is always an overlap. And the dotted line is the line at which a decision has been made there to classify people as either having the disease or not having the disease. And you can see that those with the disease includes true positives and false positives, and those without the disease includes true negatives and false negatives. And the test result, where that dotted line falls, is the one that we use from the test to indicate whether the person has or hasn't got the disease. And what we would hope to do is to optimize that value so that we get as few false positives and as few false negatives as we can. Of course, the decision will be made on safety and how many people we actually want to diagnose with that disease. So If we wanted to be absolutely sure and something was a very dangerous disease, we'd probably maximize the true positives. However, if it was a very expensive test and the risks weren't high, we may well, depending on the economic situation of our health service, we may well maximize the true negatives. It really depends where you literally draw the line. So just a note, as you'll probably have seen there, there's always a trade-off between sensitivity and specificity, and that can be represented as follows. The more sensitive a test is, the less specific it will be, and the more specific a test is, the less sensitive it will be. So the more sensitive a test is and the less specific it is, you will increase the number of negative people diagnosed as positive. And the more specific it is, the more people you will miss who are really positive. It's reciprocal. The higher the specificity, the lower the sensitivity, and vice versa. So how do we decide what is best? And this is both the art and the science of designing screening questionnaires. We make decisions about sensitivity and specificity using receiver operating characteristic curves. So what are receiver operating characteristics? Well, receiver operating characteristics were developed during the Second World War so that radar engineers could detect incoming planes or tanks or whatever objects on a battlefield. And they used receiver operating characteristics to decide the optimum levels of radar settings to find out the likelihood that they were going to be attacked or bombed. Now the idea here related to sensitivity and specificity is that the more sensitive your settings on your radar were to the fact that something was coming in to bomb you, the less specific you were about precisely where it was. If you wanted to hone down very specifically to where something was, you lost the sensitivity and you didn't necessarily know how many there were or where they all were. So there was a trade-off between the two, and this is where the idea of receiver operating characteristics and indeed the receiver operating characteristics curve, which we're going to talk about, comes from. So the receiver operating characteristic curve, or the ROC curve, allows us to combine graphically sensitivity and specificity. It allows us to find the optimal levels of sensitivity and specificity. And this is what one looks like. A receiver operating characteristic curve is a plot of the sensitivity against 1 minus the specificity. Remember, it's a reciprocal. The higher the sensitivity, the lower the specificity, so it's 1 minus. So the sensitivity is plotted there, 1 minus the specificity is plotted there. And the subsequent plot can indicate several things. If the plot is a 45-degree line, that means that your screening questionnaire is no better than guessing. In other words, it's useless. If the curve is above that line, it's better than guessing. If it falls below that line, it's actually worse than guessing. You're getting it entirely the wrong way round. So what we want to see is not a straight line, we want to see a curve above the 45-degree diagonal, and it's the area that's enclosed under that curve that is the value we use to indicate a good receiver operating characteristic curve. Generally speaking, we want at least 70% of the area under that whole diagram to be encapsulated by that curve. So an area under the curve of greater than 0.7 or 70% indicates an acceptable receiver operating curve. So how does this work? Well, essentially, you plot out the receiver operating characteristic curve using those values of sensitivity against 1 minus specificity. You don't have to do this manually these days. You can put the values into a computer program such as SPSS or MedCalc. Other programs are available and it will do it for you. And the cleverest of these programs allows you to play about with the actual levels of sensitivity and specificity to maximize the use of the questionnaire. And along that blue line on that curve there, and we'll show this later, those are the actual values on the screening questionnaire. So you can actually find the value in the screening questionnaire where the sensitivity and the specificity are maximized. Usually that's just done by a 45-degree line in the other direction, as we will see. So let's use a real example, the paid questionnaire. The paid questionnaire is the problem areas and diabetes questionnaire. It's got 20 items. It's on a 5-point scale. And for example, asks, are you feeling depressed when you think about living with diabetes? From not a problem, 0 to a serious problem. And of course the score ranges from 0 up to 80. So here is an example of the questionnaire. More questions. So if we plot out the receiver operating characteristic curves, this is what we get if we use it to screen for clinical depression. You can see that there is a curve which is above the 45-degree diagonal, and here there's a dotted line, and you can see on the red line, which is the curve, these are the actual scores from the questionnaire. So we can see that the best value is around 37.5. It's between 37 and 38. That's the best value on the questionnaire to indicate good sensitivity and specificity, and would be used to make decisions, or could be used to make decisions about screening for clinical depression. Just for completeness, it can also be used to screen for subclinical depression, and of course the scores are lower. It screens subclinical depression at about a score of 34. So I hope that shows you how receiver operating characteristic curve can be used and how it's useful. So how do we actually decide the optimal levels of sensitivity and specificity? Well, as you saw there, a 45-degree line is one way of doing it. You can also calculate them using something called the Uden index, and the Uden index, or J, is specificity plus sensitivity minus 1. That also gives you a value that you can use to set your diagnostic value on the questionnaire. So the Uden index indicates on this particular example here a point there, which is roughly where the 45-degree line would go. So you don't need to plot these things out. If you know the sensitivity and the specificity, you can work out that value. Here you can see, just as a matter of interest, the area under the curve is 0.938. That's an excellent area under the curve, an excellent rock curve. Sensitivity 88%, specificity 88% as well. Sorry, sensitivity 85%, specificity 88%. That's excellent. Positive predictive and positive negative values are also very good. But that's just an example. It doesn't relate to the previous example that we used. I'm just using that to show you what the Uden index would give you on that curve. So, having mentioned positive predictive and negative predictive values, let's have a look at those relative to sensitivity and specificity. How are they useful? Well, I don't want to go into this in a huge amount of detail. It's something that you are welcome to read up on. But this excellent paper in Perspectives by Robert Trevathan, Sensitivity, Specificity and Predictive Values, Foundations, Pliabilities and Pitfalls in Research and Practice, is an absolutely excellent paper which takes you through everything more or less that I've talked about, and also takes you on to the predictive values. And in the paper, he says that arguments are made that sensitivity and specificity should usually be applied only in the context of describing a screening test's attributes relative to a reference standard. In other words, that's where you have the values on the questionnaire and you can describe those relative to the absolute diagnosis as we've just shown. In other words, it's a necessary step. It's more related to research and the development of the instrument. However, he goes on to say predictive values are more appropriate and informative in actual screening contexts. So it is necessary, and it's becoming increasingly common not just to rely on sensitivity and specificity, but to calculate the predictive values. And these can be done, as you saw earlier, very easily from the values in the contingency table. They're not difficult to do. But of course, we do need to know what they mean. And the positive predictive value, of course, is the ability to find out if somebody really has the disease when it's used in the real world. And the negative predictive value is the converse of that, the ability in the real clinical situation to find out whether somebody does or doesn't have the disease. So these are the actual positive predictive and negative predictive values indicate what will happen when you actually use the questionnaire in clinical practice. In the paper, there's this excellent table going through a series of 5 different screening questionnaires. These are real questionnaires, they're all referenced there. One on shoulder pain, one on carpal tunnel syndrome, 2 on peripheral artery disease, and 1 on aspiration risk following stroke. And you can see that from sensitivity and specificity values, you don't necessarily predict what the positive and the negative predictive values are. For example, the first 2 examples there, shoulder pain and the carpal tunnel syndrome questionnaires, are very instructive. In one, the sensitivity is very high, the specificity is low, and in the other, the carpal tunnel syndrome one, the sensitivity is very low and the specificity is high. However, in the real clinical situation, the positive predictive values for those are both very low and the negative predictive values are very high. I'm guessing that indicates that questionnaire isn't actually all that useful clinically. The peripheral artery disease example shows that sensitivity is good, specificity is excellent. It's 100%. I imagine that's 99 point something percent. I don't think specificity can ever actually be 100%. And there the positive predictive value is very high, but negative predictive value is about 50%. And for the other ones, we see a range. For the aspiration risk following stroke, sensitivity is moderate, specificity is very high, positive predictive value about 50%, negative predictive value is very high. And the peripheral artery disease one, the second example, at the bottom of that table, probably is the best performing across all of these parameters. It's got good sensitivity, good specificity, good positive predictive and good negative predictive values. There's not really an agreement out there as to what the best values are. Clearly they've got to be reasonably high for the questions to be useful. And I think I said before that it's really related to the severity of what you're trying to screen for. If it's very severe, you'd probably want the positive predictive value and the sensitivity to be very high, and the converse if it wasn't too risky and you didn't want to waste resources. The important thing is that for clinicians, they know what these values are so that they know to what extent they can rely on the questionnaire as a screening tool. Clearly, screening tools are only one part of the story of making a diagnosis, or indeed of screening someone. They provide a value which may be useful for the clinician in order to ask further questions, not necessarily going for a definitive diagnosis, and subsequently making a decision about diagnosing that person definitively. So screening questionnaires are just part of the arsenal of clinical practice. Nobody makes definitive decisions based on them. They use them to help them to make decisions based on other clinical parameters. That goes for nursing staff as well as medical staff. So to summarise, diagnostic or screening questionnaires only work when you've got a binary outcome, yes or no, in other words, a diagnosis. Sensitivity and specificity are antagonistic. When one is higher, the other is always lower. Sensitivity and specificity can be combined to find an optimal level of each. Receiver operating characteristic curves help us to optimize diagnostic and screening questionnaires. And finally, positive predictive and negative predictive values are helpful in real screening situations. That's my email and my Twitter account and my WeChat account if you use it, and you can find out about me on ORCID. Thank you very much for listening.